We may have started a new pattern here. We'll give you an option on the bench or on the table. Healthcare Association, New York State, Haney's, Dennis Whalen, President.
Good afternoon. Chairman Young, Chairman Farrell, Health Committee, Chairman Hannon, and committee members. Our comprehensive written testimony has been filed, so I am simply going to summarize our key points and talk to you for a few minutes about the larger dynamics underway in healthcare and why they are important as you consider what should be done in a final budget. The hospitals and health systems across New York State have fully embraced the work of transformation. They're investing in growing the abilities of their clinical staff, their healthcare workers, in bringing advanced technologies to patient care, restructuring their services that expands both their ability to provide more complex care, as well as to increase their capacity to provide primary care and wellness services. In a typical year, 8.5 million patients are treated in our hospital and health system emergency rooms. 2.2 million patients are admitted to the hospitals, and more than 53 million outpatient visits take place in their clinics and offices. They remain the 24/7, 365 ever-ready point of response for medical and other emergencies, from outbreaks of a new disease to the heart attack or car accident to the organ transplant or the mass disaster. Our hospitals and health systems are also among the largest employers in every region of this state, providing more than a total of 777,000 jobs. They generate $138 billion a year in economic activity, which accounts for more than 10% of the state's entire gross domestic product. And they provide billions of dollars of free and subsidized care each year. The decisions you will make as you negotiate and craft this budget will impact the ability of every hospital and health system to continue their important work. And it will determine how quickly and how effectively healthcare transforms in New York, and whether our system remains stable and durable as these changes take place. I've described the governor's proposed budget as a work in progress. While it contains positive recommendations, it fails to address significant fiscal issues that already exist or which may occur in the upcoming fiscal year. Importantly, and this is a point that many of you have talked about this morning, and to emphasize this as a context, health providers in this state are awaiting more than $3 billion that has been previously proposed, negotiated, appropriated, yet is still not out the door. Nearly half of that, $1.2 billion, is from the 2014-15 final budget. In his executive budget, the governor proposes ambitious, multi-year visionary agendas and plans for key areas of policy and infrastructure, but healthcare is not among them. We recognize that multi-year reform is taking place for Medicaid via the federal waiver, but the overall task is much broader and diverse. And when undertaking complex and challenging change over a several-year period, there is great value in predictability of investment, just as there is in a common understanding of the roadmap of where we are going and how to get there. In regard to specific recommendations in the executive budget, the governor's budget proposes $195 million in capital dollars, but in doing so reduces healthcare capital $100 million on a year-to-year basis, eliminates $300 million in funding that was promised last year for healthcare upstate in Oneida County. Importantly, over the last week, we understand that meetings with the elected representatives in Oneida County, the governor's office, and the Department of Health have been productive, and that a commitment has been made to provide funding to Oneida County. We support the restoration of the previously promised capital funding for healthcare upstate, as well as the critically needed new $195 million. While some have characterized the need for capital only as a means of fueling and permitting partnerships where large systems consolidate with smaller institutions, the need is more complex than that. Capital dollars are needed to allow those institutions who face special challenges, such as being in a rural area or serving as a critical access hospital, to transform their operations. It enables hospitals that are seeking a partner to stabilize their balance sheets, to go into that partnership on an equal footing. It does enable stronger hospitals and health systems to enter into partnerships without weakening their own balance sheets. And it will enable hospitals that remain independent to do so, including as they transform themselves using new models of care. We are concerned about a number of issues that are not addressed in the executive budget. Healthcare providers are awaiting more than $3 billion in outstanding state commitments, as I mentioned. No provision is included in this budget that would increase the timeliness with which dollars get out the door and critically needed funds are distributed. Hospitals and health systems across the state will face a $570 million impact at the point of full implementation of a minimum wage increase that's proposed in the executive budget. There's no provision included in the budget to mitigate the impact of this increased minimum wage. And it's important to note that the necessary actions to do so should be implemented in a manner that holds harmless the Medicaid global cap. The amount due to hospitals throughout the state as the result of non-payment for services resulting from the collapse of Health Republic is approximately $200 million. Similarly, there's no provision in the budget to pay those providers for the care that they have provided to their patients. And separately, we note that in recent past sessions, discussions have occurred regarding potential legislation that would have enormous financial impact on hospitals and health systems, including imbalanced medical malpractice proposals and mandatory nurse staffing ratios. As you review the executive budget and develop your own one-house budgets, I ask that you consider both the current state of healthcare and the best pathway to achieve the goals to which we all aspire. It's important, I think, to understand our starting point, and I just want to offer a few facts about the current state of healthcare in New York. Our hospitals and health systems are fragile. Hospitals in New York State have the second worst operating margins in the United States, and they are far below the national average. Nearly 3/4 of the hospitals are in fair or poor financial condition. As you've heard this morning, 28 hospitals are receiving special funding to ensure that they can continue to stay open, and many are rushing toward that to meet that eligibility criteria. Our healthcare infrastructure in New York is the 6th oldest in the nation, and it's important to remember that over the next 10 years, $27 billion in federal cuts will be undertaken in New York, further destabilizing our institutions. Therefore, the challenge is how to reconcile the current state with our goals so that we can chart the right path forward. We look forward to working with you over the next 9 weeks to craft a budget that will enable our hospitals and health systems to continue their transformation in a way that protects access to care and offers a degree of stability in the midst of intense change. Thank you, and I'd be happy to answer any of your questions.
Thank you. Questions?
Thank you, President. So Senator Gustavo Rivera has a question first.
Thank you, Chairwoman.
Or more, maybe.
Thank you, Chairwoman. There you go. And just to Dennis, thank you. And if you have some issues down there, you can always cop the squad over here. Be good. We saved it for you. I have a couple of questions regarding. I just went through your. By the way, I also thank you for just giving us the highlights and letting us ask questions. That's always most efficient. Particularly, I'm concerned, and I'm concerned about how you folks view the increase on the $15 minimum wage increase, right? And obviously, it's something many of us, as I said earlier, have been fighting for just across all different job classes across the state of New York. you have a sense that it will be, and it will have a serious impact on your particular industry. So I wanted to ask particularly two questions. First, as far as explain to me, as far as the estimates, you include not only the salary itself, right, which will be done in a phased in fashion, and we still got to figure out exactly what that is, as the folks from the governor's office said this morning, or the health department said this morning. But you include not just the salary, but also what you call compression, spillover, et cetera. I want you to explain that to me and why do you think that it was important to include that in the calculation.
Sure. I should say that we've done this estimate in cooperation with the nursing home associations and the home care associations. And the total impact for that group of the full rollout of minimum wage is $2.9 billion. At full implementation.
Full implementation, so we're talking between 2016 and 2022, I think it is?
Yeah, you've got a differential roll-in with New York City and then rest of state. And it has three components. The estimate has three components. So the first is the direct wage impact of moving individuals who are below $15 to the $15 level. And then there's the compression factor. And when you talk to labor experts, that occurs when a lower band of salaried employees moves up and bumps into the next higher band. So those with increased responsibilities above those who you are now increasing to $15, you'd have to do some commensurate change in their salary level to reflect their level of responsibility. And the third component is what you might call indirect, but it's as your salary changes, so does your employer's obligation for Social Security, workers' comp, and a whole series of other areas where you are contributing on behalf of your employee. And we're happy to share this methodology and our numbers, as well as how that impact rolls out differentially on the geography across the set of years.
I would certainly appreciate it.
I think year one, it's roughly, depending on what you do about compression, it's a $50 to $100 million impact on the hospital side.
And does your estimate, do they include Medicaid, just Medicaid costs, or do you include non-Medicaid costs as well?
The issue of whether or not Medicaid is used as a tool to somehow compensate or mitigate this cost of wage needs to be approached carefully because of the difference around the state in the proportion of patients that are Medicaid. So there are some institutions, particularly downstate in urban areas, where there's a very high percentage of patients that are Medicaid, and you could do some adjustment. As you move to areas that have more Medicare as opposed to Medicaid, you would have to do such an adjustment on the Medicaid side that I think you could possibly run into disallowance problems in Washington, because you'd be paying for the same service at a fairly radically different level.
And lastly, since I asked the folks from the health department this morning, and you obviously have the experts that crunched all these numbers, have you folks calculated whether there'd be some cost that would be offset by workers transitioning from Medicaid eligible to non-Medicaid eligible as their salaries go up?
I don't think we have factored that particular item in, but we could certainly look at it.
Okay, thank you.
Senator Hannan?
Mr. Whalen, right along the theme that Senator Rivera has raised, if you tried to channel money to healthcare providers by the Medicaid system, you run into the third rail of violating federal rules, because upstate with far less of Medicaid paying in a institution, you'd have to raise it even more. Correct. And contrasted with downstate, you'd raise less, but then you'd have two systems. That's verboten. But if you started to then look at whatever the different formulas that might be available to give money to hospitals, nursing homes, home health care, trend factors, grants, et cetera, then you probably are starting to run afoul of the global cap that the state has made a mantra, and not to violate. So I just don't know, is there some other path that we could do this with?
Well, that's why we've emphasized the need to do whatever is done to address this problem to be neutral to the Medicaid global cap. Otherwise, you are correct, you would run right into that. So taking a look at the array of things where revenue is even moved outside of hospitals, whether that's the various assessments or taxes on gross receipts, there are lots of things that occur that if those were changed could result in a revenue flow to hospitals that might be able to be accomplished without presenting a global cap problem, or to simply do it as neutral to the global cap, even if it involves Medicaid. So you would have to temporarily, or for this purpose, increase the global cap.
But it would need some type of adjustment to existing systems.
That's right.
Thank you.
Thank you, Senator Hannan. Senator Savino.
Thank you, Senator Young. So I'm just going to follow up on the questions that some of you answered some of the questions I had when Senator Rivera posed them to you. So let me just make sure I understand this. You're not necessarily opposed to the concept of raising the minimum wage for the workers if the state fully funds it.
That's correct.
Okay. So, and I think what I heard you say was that you would prefer that we fully funded it as opposed to raising the Medicaid cap. Is that also correct?
No, that if any portion of Medicaid is used to mitigate those costs, it should be done in a way that does not negatively impact the global cap.
Okay.
So we don't want to use up global cap room for this purpose.
Right, and the figures that you gave us about the full cost, which would not just be the minimum wage workers now, but potential wage compression.
Correct.
Is that fully funded to the $15, or is that this year's cost for the first step? Because remember, this is a multi-year implementation.
This year's cost, again, depending on what you do with the compression issue, would be for hospitals between $50 million and $100 million. Over the full implementation for hospitals, that cost is $570 million. And if you add in hospitals, nursing homes, and home care agencies, that's a $2.9 billion, but again, that's at full implementation.
Full implementation.
So 15 everywhere in the state.
Right, and on the compression thing, because I heard that raised at the minimum wage hearing that Senator Martins and I had about a month ago. Whenever the minimum wage has gone up 3 times now in the past couple of years, we had 3 separate increments. Every time the minimum wage goes up, do you also then raise the wages of other workers who are above minimum wage?
To the degree that it bumps into that salary band above that, and it's required to do so, yes.
So have you
Right,
predicted?
because you wouldn't want to have
okay.
people with disparate responsibilities being paid the same.
So you have a $9 an hour minimum wage individual now. And what would the next salary band be that would be affected by this? Because we're talking about potentially a 60% pay raise over full implementation at the lower end, correct?
Yes.
So do you have, like, how many workers would be in the next band that would be slightly above it? If you know. If you don't know, that's okay.
Yeah, I don't. We've worked with labor experts, and I'm sure they can put something together for you.
The majority of the employees that are affected by this, aren't they unionized, though?
You know, it depends where they are in the state, whether their facilities are unionized or not. Typically, those people most affected would be, you know, physical and corrective therapy assistants, medical transcribers, orderlies, housekeeping staff, folks
Right,
like that.
but for those who are covered by a collective bargaining agreement, wouldn't those, you know, wage compression issues be the subject of negotiation with their union?
I don't know. I can't answer that question. It's a good question.
They probably are.
But, you know, again, I think the argument would simply be that, you know, you have individuals with different levels of responsibility. You know, it's like happens in the state. Individuals get raised, so you have to have the supervisor, you know, raised a commensurate amount.
Okay, but most importantly, you're not opposed in concept. It's just, how do we pay for it?
Correct.
Thank you.
Thank you, Senator Savino. Senator Kruger.
Thank you. So in your testimony, you go over how much capital money hospitals are owed and we're behind on. I guess I'm sure there's lots and lots of detail somewhere of where we're behind and by how much. But I know, speaking for Manhattan, where I represent, everybody keeps changing what they're planning on doing. They're moving to more ambulatory care, they're closing beds. Is it reasonable to say the state ought to reevaluate how it's made its capital commitments in light of a seems to be fairly dramatic change in the patterns of in-bed hospitals versus ambulatory care centers?
Yeah. So Senator Kruger, the first point I'd make is that these dollars on the capital side are not exclusively available to hospitals. They're available to, nursing homes, clinics, and other parts of the system. Secondly, the RFAs for these dollars spoke exactly to the point that you're raising, that transformation is needed. In some cases, it was asking for how a more sustainable, different way of delivering care would be provided going forward. There are, the biggest chunks of this are the $1.2 billion that was appropriated in 14-15 to help transform through capital assistance programs. Then there's the $700 million for Brooklyn. There's the $300 million for Oneida County. There's a 355 approximately chunk for what were called the essential providers. So I think it speaks exactly to the kind of issue that you've outlined, which is take where you are now, understand where we need to be, and what do you need assistance with going forward to get to the new place.
And since you lined out those items, I know Brooklyn's got its own set of issues still. Are there actually proposals in the pipeline, and it's the state agencies that have failed to say, yes, you checked all the boxes, here we're going to DASNY to help bond for this?
The 1.2 million,
billion.
those 1.2 billion has been in with applications for quite some time. Our understanding is that the health department has completed its review of those. For the essential provider RFP, similarly, those have been out. The responses have been filed. We understand that the department is finished or close to being finished with the review of those applications. For Brooklyn and Oneida, no offering has yet been outlined or requested for purposes of spending those dollars.
I hear your frustration. There was a quote somewhere in a paper today, I think, or perhaps a blog, that many of New York State's capital plans are more aspirational than actually getting done. So yes. I think for the sake of healthcare, we want these projects to actually have real bricks and mortar sooner than later.
Right.
Thank you.
Everybody struggled. The dollars are not aspirational. They're real. They're real and sitting there and available.
Thank you.
Thank you, President Whalen, and want to welcome you also, and thank you for your testimony. As you know, the topic of hospitals is very important to me in my district, and I want to thank you for all the information that you've given today and also the information you've given in the past. I think you're right on the money, so to speak, as far as the fiscal stresses that our hospitals are under right now across the entire state, particularly regarding capital and operating funds, and how do you transform yourself moving forward so that you can have the high-quality delivery system that our residents in New York State need and deserve to have. I was hoping you could just comment a little bit further on the state of rural hospitals and what you see in the future for them.
I think as you know, Senator, there have been a series of hospitals that serve rural communities that have had difficulties over the past couple of years. Some of those have involved partnerships that didn't work out. Some of those have been the struggle to transform the services, moving to a substantially a set of more outpatient type services, but then community concerns being raised about obstetrical care or trauma care or other things. And I think part of the frustration is, and it speaks to this issue of understanding where we want to go, is that it seems we're almost solving these issues on an ad hoc basis each time there's a crisis. Instead of thinking in a more principled way beforehand of what sets of services and what sorts of configuration could be put together that serves communities where, because of geographic challenge, and sometimes there's a weather factor in that, in other words, easier to travel distances in summer months and tougher to travel distances in winter months. What are the models? How do we build telehealth, telemedicine, into this set of services? What types of arrangements do we need between hospitals? We've done this in areas such as stroke, where we have hub and spoke model designations by the Department of Health, and prearranged protocols about transfer of patients and other things. And I think you need some thinking about that sort of clarity in terms of the models and how they would be supported. Instead of solving these on a crisis basis, where community tends to get very upset because they don't understand that there's been some thinking, that there's a preset of choices on a menu for how you can put services together that will meet the needs of communities in rural areas, and couple those with reimbursement or other supports so that these remain going, healthy concerns, instead of just hoping that you're close enough to a large system that can come in and partner and solve your problems that way. It doesn't really. Certainly systems come in and lots of affiliations are underway in New York that sort of mirror that model. But even there, systems are going to be taking a look at the level of services that are needed. How do I attract physicians, nurses, and other healthcare personnel into these areas if it's going to be worry on a year-to-year basis whether or not the structure that's there will truly be supported.
Right on target, so thank you very much.
Thank you.
Thank you.
We did that already. Dennis Rasky, President, Greater New York Hospital Association.
Ken Rasky.
Yeah. What did I say?